Right now, there's a gap how pain is measured and monitored throughout Europe. And that's quite a challenge. And I would like to kick off the session with presenting my co-moderator. He is professor at the University of Marburg since 2012. He is co-chair of the ICD-11 working group on the classification of chronic pain. And please welcome, and would you please welcome, Wilfried Rief. And I also would like to welcome, maybe take this, Ulrich Vogel, Cesar Margaret, Joanna Maria Ligor, and Santiago Calvo Ramos on stage with your applause. Thank you very much. Unfortunately, he cannot be here in person. Yeah, please take your seats. And we have another video message from Robert Jakob from the WHO. Please. No, we don't have? Okay, we're working on that. Oh, here it is. Can you hear us?
I can hear you. Thank you very much. I hope you can hear me.
Loud and clear. Thank you for giving your message and statement.
My pleasure. So should I start?
Yes, please.
Okay. So I understand that yesterday there has been some discussion on the ICD-11, and when it comes to coverage and spread of an information system that is to be useful, let's say in the particular area of pain, I think thinking of the health system as an integral system, of course, we want to have this as part of one documentation system. And this is what we had in mind when we were doing the ICD-11, that you were saying, oh, we have a whole range of different uses, and one would be certainly research, your research and documentation of pain, clinical terms in relation to pain, costing in relation to pain. Causes of death is not so applicable, cancer registration also not, but if you see this whole range of different uses, they make sure that the ICD-11 can be used as the documentation system in health, and being pain integral part of it, thanks to the work of the Society of You. We have a tool that will deliver certainly the information that you need. Now, looking at it, what is ICD-11? So ICD-11 is much more than just diagnosis. You may thinking of pain, others may thinking of injuries, signs, symptoms, and findings, and many more. And you see here highlighted the parts that are new. One part is certainly something on traditional medicine conditions. And if you ask, why did he put this text here on the side, they're saying it's a synthesis. It's not traditional Chinese medicine, because just yesterday or the day before, The Guardian again published a wrong article claiming that WHO supports traditional Chinese medicine. And I just say, no, the ICD-11 contains categories that are broad categories for this family of traditional medicines that does exist, and we don't include treatment, just to be this very clear, because also I think some scientific societies in Europe are writing letters at this point in time. Now, another thing here in the ICD is, of course, what is new: antimicrobial resistance, anatomy, laterality, substances. To what extent is this relevant for you? Well, it's very clear. If you can localize the pain specifically, normally the normal categories of ICD may not be detailed enough. And with this anatomy, you can essentially determine every minute detail of the body that is related to pain or pain treatment. The same for laterality, and substances would allow to document, for example, that medication has been given, and or if there have any complications in relation to medication. Similarly for devices, and one very important new component in the ICD that will certainly be helpful in any kind of research and clinical monitoring is the functioning assessment that we do have in the ICD-11. This is a special section that has been developed following long discussions with a specific topic advisory group, where in the end the point was we need to be able to describe in general how parts of a person or the person overall functions. But in the end, what is important is that a person is able to do in the daily life or in the work life the thing that the person wants to do or needs to do. So, activity and participation being part of the community. And with this functioning assessment, you can essentially collect information that you can process through what we call the WHO Disability Assessment Scheme that allows you to calculate a score, and then you can really track how is the fitness of the patient increasing in the course of the treatment, or how it is it not increasing. So both things, well, you can track this there. Besides that, of course, you can describe the overall functioning. Now, looking at the ICD structure, I think what you are seeing now is probably familiar to you. It's the overall ICD-10 structure. And from the outside, the ICD for this kind of statistical aggregation has changed only to some extent. And if you look at this, you see the things that are blinking now. This is what is new. And let's start on the left side. The immune system and blood have been split, so that finally we can lump together all immune system diseases in one chapter that allows some visibility even at high level international statistics, whereas in the past that information was hidden somewhere in musculoskeletal for the rheumatic diseases, in metabolic diseases, and many other places where they had been placed historically. The other thing that is new, well, we discussed it already, is the traditional medicine, ancient Chinese roots. That's the word, not TCM. And we will be working on having medicine as practiced in India and other countries, so that really one can track these diagnoses in conjunction with the diagnosis of the standard modern medicine, so that finally is possibility to have comparative studies on outcome, progress, prognosis, and other aspects. Now, what is also new is a separate section for sexual health. I know that's not specific for pain documentation, but it is relevant to emphasize that there are certain conditions, for example, like gender incongruence, that are neither a real disease nor they are a mental disease, and they are also not a somatic disease. And so having a chapter by itself allows these conditions to be looked at in a very neutral fashion. And on the other hand, the people can, if they want, still access the health system. Now, here we see also what has been added a lot. There is certainly the acute pain, and there are different pain categories already in ICD-10 and now in 11 in the nervous system in the neurology chapter. But a lot of work has been done on chronic pain in collaboration with your team. And looking now at the other part of the structure, you have seen the traditional structure, but this is a simplified view on what happens behind the scenes in ICD. ICD-11 is built on an ontological structure. And I think yesterday, my colleague Nenad has shown all these kind of IT features, but all the IT doesn't help if no brain has said, what is the relationship between the things that are in the classification? And here you see some typical example. You have sleep-related movement disorders that could be, well, sleep-wake disorders. On the other hand, they have strong links to nervous system, to movement disorders. Yeah. Now, from a knowledge representation point of view, it means an ontological view, it could be in both places. But of course, if you want to aggregate data in statistics, we have to choose one way. And as you see here with this slightly stronger blue line, it's linked to the sleep-wake disorder primarily. Another thing that is new in the ICD-11 in its knowledge structure, ICD-11 doesn't stop with the entities that are relevant to get an individual statistical code. So here you see sleep-related movement disorders, and on the left side you see a range of individual categories that may be difficult to read, but all these categories, you see them in blue, have their own statistical code. On the other hand, you see here in the red circle a set of categories that apparently are unfrequent, and where the relevant scientific community says we don't need detailed statistics about this. On the other hand, for clinical documentation, you do not want to miss that information. And now these are lumped together statistically in a category other specified sleep-related movement disorders. But if you want to document still that detail, you can use the URI system that was explained, I think, yesterday to document this. But just as a repetition to understand this URI mechanism, everything has a URI. But at a certain level, and you see this here in the green side, the statistical detail stops. But from then on, ICD-11 is not a flat list, but is a tree that continues in the depths, or a network that continues deeper in much more detail, and allows to identify any kind of its content with these URIs. And I'm just showing here a few examples. Of course, they are not for manual coding. If you want to do this manually, one would assume that you have some electronic system around that allows you to track these rare cases. And just to give you a hint, so in the ICD-11 core, we have some 80,000 individual entities or concepts and some 105,000 terms. But as you may have heard yesterday, if you think that you also can combine anatomy and the system guides you on how to do this, you can get many more. At the moment, we are at 1.6 million, and we're just checking with this kind of combinations that are permitted whether we have more. What's the advantage for you? The advantage for you is that if you say chronic cancer pain of a certain body part, it will give you automatically the code combination, so no point of complicated manual searches of code that won't fly in the clinical context anyway, because I think everybody is coding to the minimum level necessary for not getting into trouble with administration, except for medical studies, of course. Now, ICD-11 means really more standardization. So as said, we have scientific updates and solved known problems. For example, missing information on pain, missing information on malignant melanomas and subtypes, uh, overly complication of diabetes in ICD-10 that was simplified in ICD-11, antimicrobial resistance, traditional medicine, patient safety, just to mention a few of the aspects that have been added. The other thing is that you may have seen the translation tooling yesterday and a multilingual version. With this centralized translation tooling, it also makes sure that the translations are more consistent than they were in the past, and that also increases the comparability of data across different countries, besides the fact that it helps people that are working in a multilingual environment to address the same thing with one thing and find out in the other language. Also, ICD-11 saves money, although this sounds kind of crazy because everybody is saying, oh, we have to invest money to implement ICD-11. This is true, but on the production side, one central tooling from that language generations are generated will reduce the burden of the entities that are maintaining the individual language versions. And just in Europe, I think we have some 16 or 20 different ones. So with this becomes much more easy on the maintenance side. The same is for the index coding side. But another thing that is very relevant is this much easier coding. So the coding effort becomes much lower. Actually, it can be embedded in the clinical workflow so that people are not harassed by a system, but with this kind of intelligent national language processing coding engine. This also means that you can retain more detail in a structured fashion, so that when you want to make analysis of the data, you could. On the other hand, the usual warning, I think even between two departments, you don't have the same of the same hospital, you may not have the same level of documentation. So I think it will be more something for the research and or for special documentation, like in specialized departments, to make sure that a high level of precision and good quality of data at the source makes sure that what is coded is also meaningful. Now, looking at the detail in ICD-11, just as a repetition, you can see here the parts of pain where a lot of work has been done, and you see here this kind of overview. There are still here and there some updates and edits that are made just to remind you what's there. So we have a description, we have additional information, we have diagnostic criteria, so a whole range of things that allows to even standardize the way things are diagnosed at the source, so that we are clear that if we are talking about chronic cancer pain, these things have been present, and we don't have a mixture of cases pending the interpretation of what chronic cancer pain would be. And then, of course, you can further break this down if you want, using the URIs into visceral pain from cancer, bone cancer pain. But this detail we can also do with code combinations. So if somebody really feels a lot of pain because you cannot directly code chronic visceral pain from cancer, you can still code chronic cancer pain and add a code for visceral, and then essentially we have the detail that you were looking for. The same for bone, the same for neuropathic. Now, if you want to look up pain, you can go in this ICD-11 browser and search for the word pain, and you will get a lot of pains. And you see here the structure that is focusing on the chronic again and a little bit on the acute. But you see also that, of course, there is some manifestation of pain, no surprise, in other parts of the body. Here, the size of the screen is constrained, but well, if you search in the environment, you will find much more. Um, Here we see something that refers to code combinations. So on if you go to a certain category, you will find that there's indication that, for example, cancer of the breast can be bilateral or with chronic cancer pain. And we are working on the coding engine that already, if you type out in the coding tool, very important coding tool, the bilateral carcinoma of breast, the system will give you this code combination that you see here, the 2C70 for the carcinoma of breast, and then in combination with a code that tells you bilateral. And the same is happening or will be happening in the future with adding some detail about the chronic cancer pain. But this means that we need to also manually in the system tell the system that all of this can co-occur with some chronic pain, and so that the end user can take advantage about this work done beforehand. Now, ICD 11 and pain documentation. ICD is covering a whole range of things in health. So as soon as implemented, you also get the more detailed pain use. Of course, especially in Europe, many countries are having highly integrated systems. So it may take them a few years until it can be officially switching to ICD-11. On the other hand, we are having maps between ICD-10 and ICD-11, so it would be thinkable that in specialized departments, like for you in pain, or like for other colleagues in patient safety documentation, or also in dermatology, one can take already advantage of the highly improved level of detail and quality of representation, and one can still then convert this to some simplistic ICD-10 codes that are currently required for national reporting. So with all of this, we can just say, C, to implement ICD-11 as quickly as possible, and B, just in your specialized environment, so that you can take advantage of all the work that has been put into the ICD-11 by your societies. Um, and you see here, so as a kind of last slide now, we have calculated the statistical impact of ICD-11 in mortality in that case, because we have the WHO mortality database where the single underlying cause of death is documented. And you see here some striking differences between two sections. The tall, very tall one is the circulatory system, and the smaller one in the middle is the nervous system. And the nervous system has got a huge increase in mortality because the cerebrovascular conditions were moved to the brain diseases, because cerebrovascular diseases are multifactorial in the basic etiology, but the target organ is always the same, and the trouble at prevention and monitoring is the same. And at the same time, if you go to the leftmost arrow, you see there at something that is called 04, a small bar. And this small bar, these are the immune diseases that are killing people, that disappeared in all statistics so far. But this figure will increase a little bit because with the creation with the chapter also has also a little bit an impact on how the causes of death are solved. So that's just to give you some overview. And so if you're planning to implement ICD-11, well, if you're an early adopter, WHO will give you technical support. So for example, how to integrate all these advanced tooling interfaces, application programming interface in your local software. We are producing a self-learning training, electronic one that will be online in December. We have an implementation guide, but this is more at a country level. Still, it may be helpful if you're discussing with some of your politicians on how quickly the transition should go. We have this translation tool, as you know. We have the maps, and most importantly, we have the coding tool. All of this you can access with this one central email address, not email address, IP address. It's icd.who.int. And as said, ICD is fully digital, has all the detail you want. It's online and offline available, and whoever wants can also have a print of the whole ICD or a chapter of it, and ICD will be freely accessible to everybody. There will be just a few regulations to make sure we know who is doing and who got the permission for the translations. Otherwise, it will be free for access. With this, I'll stop and back to you.
Thank you very much, Robert, and I hope you hear the applause.
Thank you.
Thank you for your detailed elaboration, and I think that's a major step for patients living in chronic pain. Thank you very much.
Thank
And ladies
you.
and gentlemen,
Bye.
I made a mistake and I apologize. I also please give a warm welcome to Rolf Detlef Trede. He is also part of this panel. Rolf Detlef Trede, where are you? Oh, maybe he'll come later. Okay. Then we come to the first question. The first question for you now is, if you measure pain, you measure the quality of healthcare systems. It's an individual response. Please make your choice. Strongly agree, somewhat agree, disagree, or strongly disagree. Make your choice and pass the iPad around. Right. I think we are ready for the result. This is what you think. So 30% say they totally agree, strongly agree. So it's more than 50% they agree or strongly agree. Back to you now. Thank you.
Thank you. Ladies and gentlemen, dear colleagues, it's my great pleasure to introduce you Ulrich Vogel. Ulrich Vogel is working in Germany at the Center for Documentation and et cetera, in the medical system. That means he is responsible for classification and documentation in medicine and in the healthcare system in Germany, which already makes him a really significant person. Further, he's also our link from Germany to the WHO, to Geneva. So he is responsible for the introduction of ICD-11, and he is already working on that in Germany. And he has a lot of experience in how to get such a system established in the national healthcare system. I think personally we met the first time about 12 years ago, 14 years ago, when I was in charge of a working group that wanted to get a new pain diagnosis established in the German modification of ICD-10. And he was extremely supportive and gave us a lot of important advice. So finally we were successful, and this became one of the most frequently used pain diagnoses in Germany. So he was our supporter, and we are, I think, the whole pain community can be very grateful for his support. Thank you that you were able to come. A warm applause for you.
Thank you very much for your kind introduction. Indeed, we knew already some time, and not only you, but also like Rolf Dieter Trader, we are working very closely. And it's really a pleasure and also an honor to me to be here and to have the opportunity to speak about our experience with the ICD-11 in Germany, about evaluation and implementation it. And I should say, as also Wilfried Reef said about my different hats I'm wearing here, my speech is given as an employee of the German government. So I'm a civil servant, to say. I'm main responsible for ICD in Germany, for maintaining and introducing and also development of the ICD. But I'm also co-center head of the German collaborating center of the HUFIC network, and as well as I'm recently be appointed as co-chair of the advisory council of the HUFIC network. So you can be sure that I will take the impressions, the speeches, and the content I've heard here over the 2 days back into the HUFIC network as well, and to share it with the colleagues on the international level of collaborating centers and also with the WHO. So getting into the topic, first my disclosure, I'm getting from time to time some travel support by WHO when I'm invited to take some meetings at headquarters, but that's it in principle. So what is the baseline situation if we talk about ICD-11 implementation and evaluation of implementation? In the first instance, I think we have to distinguish between the two major use cases we are talking about, which is mortality and morbidity. This is what I'm trying to briefly outline to some extent so that it's maybe a little bit more clearer for you also to better understand the resolution that has been adopted by World Health Assembly, which we go into little detail a little later. And then I will give you some insight about the work in progress in Germany. So let's take a closer look to the adoption of ICD-11 at the World Health Assembly in May this year. So what is always quickly said is that it's coming into effect 2022. But what does it really mean for the countries? What does the resolution say about that? So does that mean that every country has to and will have implemented ICD-11 already within 2 years or 3? Most likely not, because the countries are set up very differently if it comes to ICD-11, if it comes to ICD implementation at the moment even. So it's not by accident that here in this paragraph, it's written that the WHO has to provide transitional arrangements for at least 5 years and as long as necessary to enable member states to compile and report, that is important, statistics using previous versions of the International Classification of Diseases. So that gives quite a space, time space, open for countries to implement ICD-11. And of course that has its reason. And we will come to it in a few slides if you can see what it means, at least for Germany, to go into implementation of ICD-11. So we have to see the mortality baseline situation. From an international perspective, this is mainly about reporting single underlying cause of death. So there is one code to be reported to the WHO by the countries, and that is going into the general statistical analysis and publications. And how to do that with the ICD at the moment is twofold. One is manual coding still of their certificates, and one is automated coding with the IRIS software, which is a development of several countries in the IRIS Institute. And this is an automated system. So if we move to ICD-11, for those countries who are actually using the IRIS software, that means you have to first adapt the IRIS software to ICD-11. And that means updating and revising decision tables with hundreds of thousands rules and decision-making algorithms. So that still needs some time to do, and also you have to adapt the software itself. So how about the morbidity use case? So that is what you are primarily interested in. The morbidity use case is quite different from the mortality use case. First, there is no general ICD reporting at the moment from countries to the WHO regarding morbidity. There are very few indicators that are reported at the moment. And the morbidity use case, different to the mortality use case, which is based in principle on volume 2 of the ICD-10 at the moment, which its guidelines for mortality coding and death certificate coding, it has a huge variety of different kind of coding standards in the countries, which are applying to different use cases even. And some countries have developed national modifications. And of course, you have multiple interest and influence of multiple stakeholders, which is also different from the mortality use case, where you have the statistical offices primarily who are interested in the data on national level, but also on EU level or worldwide on the WHO level. So how do we do in Germany? We, quite early in the whole ICD development process, implemented a board, a national board for classification in healthcare, which advises the Federal Ministry of Health in Germany and also DIMD on all use case related aspects of the medical classifications in healthcare. So there are all the stakeholders, and we do have different working groups on that level. So for ICD-10, for the current version, for our annual submission process, for the ICF, for ATC classification and LOINC today, and also others. So this board undertook already kind of a survey to find out where in the healthcare system is ICD-10 or at the moment inside. Because if you want to evaluate ICD-11 for implementation in your country, you should know where the ICD is inside. And that serves up for one or the other surprise. And you may imagine that showing some of the use cases in Germany, which are quite complex to some extent, and in some cases, particularly if it comes to things like here the morbidity-oriented risk structure compensation scheme. It's, I guess, some very German typical kind of thing. So I hope you don't have that. But it's just an example. So here, this is balancing costs and budget Germany-wide based on regional morbidity between statutory health insurances. And that is calculated over 8 years with an algorithm. So you may imagine if you transit from one revision to another, you have to cater for very good crosswalking and mapping tables, and you also have to cater for the impact the new content and structure and the coding of the users have on this grouping, which is what this system is about, because it's all about grouping in many of these kind of use cases. Not only in reimbursement and case mix, there it is evident, but you have grouping in almost all these kind of specific use cases. So we really need to know where our cases go. And that is a part, or maybe way beyond, of the simple mapping tables that are provided by WHO, which are very good in the not criticizing the mapping tables, but the mapping tables do not tell you on site where your cases with their case weight go in the system. It just describes some flow of patient groups or single cases, and that is a totally different story. So it's not a surprise that the working group of this so-called KKG identified some mandatory prerequisites for further evaluation by those organizations who are in charge for the use cases. Because that's not us, that's not DIMD, that's not the classification nerds and nosologists. It's about the responsible organizations. In Germany, it's like the INEC Institute, which is in charge of the use case of reimbursement in hospital, for hospital patients. So they identified two prerequisites mainly in the first instance, which is a German translation of ICD-11. They need to know what they are talking about. So they need to know the hierarchy in Germany to the endpoint of coding at least. And also they need a detailed crosswalk table between ICD-10 GM for the German modification, because that is in use in Germany for morbidity, and the ICD-11 in both directions. And what they also, identified is that there is need for a stepwise approach regarding a political decision. Because all these organizations, many of them are statutory bodies, so they need to make the case if they spend money on implementation and evaluation. Excuse me, please, something. Is it me? Excuse me. If they invest money and spend money on evaluation and making kind of an electronic environment to process data in different directions with different classifications and to find out what is the impact for one or the other use case, this all takes some money to do so. So it's about budgeting. And to some extent, they cannot start with it. They cannot make the case spending money on something which is totally unclear when it comes into effect. Because the World Health Assembly resolution principally says that ICD-11 will be introduced 2022, but this is only related to mortality statistics, and that can just mean mapping ICD-10 mortality data to ICD-11 and not necessarily introducing ICD-11 into the countries in 2022. So there is kind of course, also a hen and an egg situation. And that is why the German Ministry of Health also decided to do some preliminary work, so funding translation of ICD-11, and also so that the users can see what the ICD-11 looks like in German, at least the hierarchy. And that is what we are currently doing, or what we already did, because the hierarchy, the MMS titles are translated now. And also the foundation will be translated, we hope, till end of next year. But this also means we have to have a quality assured translation. And that is where it comes to the relation and also to the engagement of the scientific societies and the people from the field like you are. Because what we are doing as a first draft should be qualified in a qualified process by medical experts of the field. We have so much new terminology in the ICD-11, which doesn't even exist in ICD-10, and that's quite natural. That is what the ICD revision was for, to update it along with scientific knowledge and the needs. But at the same time, this causes some challenges. This is nothing that is kind of witch work to do, but it needs to be done. And we have to engage the scientific community and the field in that work, because we cannot do it by ourselves. So the other part is that the ministry issued a project for transition analysis in several steps to find out what is the impact of a possible transition on implementation of ICD-11 in Germany. And this is in very close relationship with stakeholders and experts from the field. And we're doing it in two aspects. So we are generating a crosswalk table for ICD-10 German modification to ICD-11 and backwards. And also we are undertaking 4 workshops with experts from the field and addressing very different fields of healthcare services and sectors in Germany, as well as from a content perspective, specialities. So we will start with mental health. In December, we will have a workshop on pain, in fact, together with the colleagues from Germany, cross-cutting different kind of specialities. And another one will be about neoplasms, which is very much together with the cancer registers. And the last one will be with our General Practitioner Association, the so-called KBV in Germany, so where we will take a look to the most relevant diagnosis for general practitioners and outpatient care. So you may ask, when will ICD be introduced in Germany? And I can at the moment only say it depends. And I mean, so this is not my slide, sorry. It really depends on the engagement and a very strong political will. I also should say that, because I remind myself when ICD-10 was introduced first in Germany, we had a very strong opposition from our physicians. And in the first instance, it was just taken out of the implementation in the first instance, as we had index entries like crocodile bite and snake bite. And our physicians told us, we do not have that in Germany. What is that kind of a crazy classification? So that was that level. I do not foresee the same level of discussion now, but be aware that we have many colleagues who are not in favor of classifications, And that has very much to do, of course, how we today use the classifications. And so I think we, at the same time we think about introducing ICD-11 as such, we also need to think about how to use the classification. And what does coding mean, in fact, in the future for physicians and all those who are caregivers to patients? I do not see any physician in the future who is doing coding. I mean, that is ridiculous to me. It's ridiculous today or too, but in the future particularly, we should find different kind of approaches and solutions for that. So we will very strongly support all these initiatives with our capacity or with our knowledge, but we really need your cooperation, and I really appreciate that. Thank you very much.
Thank you, Ulrich. Thank you very much. And for your interesting insights and also critical comments. That's very interesting. And now he's here. Please, a warm welcome to Rolf Detlef Trede. He was in a telephone conference. Please welcome also him. So, we'll proceed with Cesar Margarit, who will share experiences from the SIP national platform in Spain. He has been a board member of the Spanish Pain Society since 2012 and a Spanish representative of the International Association for the Study of Pain, IASP. Cesar, the floor is yours.
Thank you very much. Good afternoon to all of you, and thank you, the organization, to let us share our experience of the Spanish platform SIP. And I'm going to talk on behalf of all the platform. This is my conflict of interest. I have received grants, and I have been a speaker for several companies. And this is the SIP platform Spain. As the big brother EU SIP, we are composed by EFIC and the representative in Spain, Spanish Pain Society, with two alliances. One with the Healthcare Society and with the Health Director Society, in order to improve this core that we'll explain later. Also with the Pain Alliance and Citizens and other pain patients organizations. Sorry. Our international background has been great during these years because we have participated in all the SIPs before. We have received support by our politicians, and we are one of the biggest number of SIP supporters. And some of the guidelines have been published according to the SIP rules and are published in the website. According to that, last year, the SIP platform Spain was launched in the middle of the year, and at the end of the year, in December, we held a symposium in Madrid, and the themes that we choose for that symposium, for the first meeting, were according to the pillars of the SIP Europe. One of that, marked in red, is the pain as indicator of quality of care. As a result of this meeting, we saw that we didn't have any indicator, and we have to move to indicators in pain. Which were these indicators, we didn't know exactly, but this is the gold standard we should fight to have in our health system, but in a realistic way of life, we cannot do it now. So we have moved to these three experiences that I'm going to tell you that are from the heavens to the earth, the real world evidence that we think we have in our country, in our health system. The first experience I'm going to share with you was pain as indicator in acute pain. As a roadmap that we don't have pain indicators now working in Spain, we would like to go from acute pain to chronic pain, and so establish a good system and a network with all the agents acting in that. We have worked with pain unit experts and also quality assessment experts. All this group has worked to choose which are the pain indicators in acute pain. They have used a Delphi survey, and they are going on now, and maybe in 1 or 2 months they will have results to be implemented and then to be evaluated. What we want to do is a consensus proposal also in alignment with all the national and regional proposals, and also the dissemination to all the pain units and all the hospitals. This is one of the activities that is going now. The second one is best practice in the national health system. It's best practice in pain awards, and they are done by the Ministry of Health. All activities that they can be audited. Quality of life is one of the goals of this best practice, and they have indicators can compete to have this award. And this is like a laboratory to know in a small world if these indicators can work or not, and they could be elevated to regional or national health strategies. But we don't know the external validation of that, but it works to see if what can we do or not. The third experience I would like to share with you is the chronic pain indicators. Nowadays, there is an update of the Spanish cancer pain national strategic plan, and they have asked us to the SIP platform Spain to propose some cancer pain indicators. It will be a chance to be in chronic pain, and maybe next steps will be chronic non-malignant pain. What refers to the implementation of ICD-11, we are not very near to be implemented, and it will take a lot of time because there is a thing that is not in the political agenda in Spain nowadays. So for next steps for our platform, in the next meeting 2020, we are going to introduce again this pain as indicator and to evaluate if these experiences have worked well or not and what we should do next time. Thank you very much.
Ladies and gentlemen, our next speaker is Joanna Marie Gligor, sorry. She is head of a unit at the DG Santé, responsible for a European reference network in digital health. Before joining DG Santé, she worked in the Secretariat General of the European Commission in employment and social affairs, and she started her career in European institutions in the cabinet of Commissioner Orban. So very welcome, and the stage is yours.
Thank you very much, ladies and gentlemen. I think my speech will be more concise because most of the things have been said already, and my predecessors have entered into a great level of details. I would like to tell a little bit what we are doing at the level of the Commission for the digitalization of the health systems. My unit is basically supporting this in the European Union. As you know, health is a national competence, so the member states have the main role in this respect. And we are trying to support this through the work of the e-health network, which is a network of member state representatives, the national agencies responsible for e-health. And I must admit that there is a big push forward from several member states in digitalization of the health systems. Several laws have been passed in several member states, and I think Germany is one of the champions in this respect. We see it like locomotive, as we say in French, in pushing basically the digitalization in Europe. And of course, the implementation of ICD-10 or ICD-11 is at the forefront. Now, in this area, what we are doing and what we are supporting the member states to do is the exchange of patient summaries and e-prescriptions. Many of the countries are using in this context either ICD-10, some are also using ICD-9. The information which is basically provided in the context of the patient summary exchanges can also be relevant for measuring pain. For instance, information related to the medication, to the medical conditions, to the past surgery, etc. But there is not very specific information related to pain. Now, what we are also trying to support member states to do is to exchange electronic health records at large, much wider than only patient summaries. And in this context, the European Commission has adopted in February 2019 the so-called electronic health record exchange format, a Commission recommendation, in which we are supporting fuller, more comprehensive exchange of electronic health records. Beyond patient summaries and prescription, we are aiming at exchanging images, lab results, and discharge letters. And there is a process which is called the joint coordination process, in which we are aiming at taking forward these exchanges. I must admit that I'm quite interested in hearing your views, actually, in what would be interesting to exchange in the future, apart from what I have just mentioning, because it's not only relevant in the cross-border setting where a patient travels from country A to country B, goes to emergency in country B, the doctor in country B sees him or her and gets to know more information about his case. It's also relevant in the context of the patients moving from one hospital to another in the national context. And from this perspective, interoperability and having the same type of information is absolutely essential. And I would be very interested and very curious to hear more about your views. Another area on which we are working, but which is maybe even less related to pain as such, but it impacts on this, is the European Reference Network for Rare Diseases. And we are trying to support doctors in the member states to provide with advice and on diagnosis and treatment for patients with rare diseases. And there are several of these CRNs which among the areas that they are covered can also be symptoms related to pain. And I'm thinking about the ERN related to cancers. I'm thinking also the RECONNET, for instance, rheumatological related ERN. I'm also thinking about the endo-NMD, the neuromusculoskeletal diseases, etc. So my perspective is more from a future development and future needs in this area. And I would be very interested to hear your contributions and your thoughts. Thank you very much.
Thank you, Joanna, for staying in time, which saves us a little bit of time and offers us more time for discussions later on, which is great, I think, and in the sense of everybody. So then our next speaker is Santiago Ramos. He is economist and works at the Department of Public Finances of the Directorate General Economic and Financial Affairs at the European Commission. So he'll bring our attention to financial issues, which is very important. You're very welcome. The stage is yours.
Thank you. Okay, so yes, I'm Santiago Calvo Ramos. I work in DG ECFIN of the European Commission, and I'm going to tell you a little bit about how we would look at indicators on pain and what could be the advantages of having indicators of pain as a measure of quality of the outcomes of the health system. Okay, so this is my disclosure of conflict of interest, which is fairly brief. Okay, so in terms of the work that we do on the fiscal sustainability of health systems, a lot of our work is motivated by what we call the Aging Challenge, and we publish every 3 years, working together with member states, what we call the Aging Report. And this basically projects the increase in expenditure for both health and long-term care systems due to aging, but also to non-demographic determinants. So the beginning of this story is that basically we expect the EU's population to become much older over the next 50 years. So by 2070, a larger proportion of the population is expected to be above 65 basically than currently, with the population between 15 and 65 shrinking quite a lot. And of course, that has implications for health systems and also for the cost and the expenditure of health systems. So our projections are basically that this aging plus non-demographic determinants and drivers are likely to increase the expenditures as a proportion of GDP for both healthcare and long-term care systems. And basically in the thick dark lines, you can see our main scenario, but you can also see our risk scenario in the discontinuous lines. So the potential for increasing expenditure is quite high as people are older, typically frailer, and life expectancy increases, and therefore more care is needed. Now, this can have implications then for the fiscal sustainability of EU member states. Fiscal sustainability is basically whether providing care is affordable, given the tax income that we have and the debt that we already have. So that's more or less the definition that we use. And therefore, it becomes very, very important to try to think of how systems can be made more efficient. Because if health and long-term care systems can be made more efficient, then we can still provide accessible, good quality care to the population, and we can afford to do so. So therefore, that's why. And we produced a few years ago a joint report on healthcare and long-term care systems, together with member states again. And this was basically a summary of the scientific consensus on which are the interventions that can improve the efficiency of health and long-term care systems. And it also has a volume 2, which we have updated now in 2019, which has a description of the systems of each member state, co-written with the member states, and discussing particularly the challenges and possible solutions in terms of improving efficiency. Okay, so just to give you a flavor of the kind of things that we're looking at, we're looking at things such as containing costs on hospital and pharmaceutical care, investing in primary care, which is typically more effective, leads to better outcomes, and is also more affordable, and prevention, dealing with budget overruns, fiscal pressures, etc., improving the quality of information, and I think it's here where pain indicators actually are very, very relevant. And then improving the governance in general in terms of how the integration both between healthcare and long-term care and between each of those systems. Now, in terms of quality indicators, basically, what I see as the advantages are that they are a way of reflecting the quality of care more accurately, since these are outcomes that are typically seen as byproducts of the care in some cases. In other cases, they affect the quality of life. But in long-term care, you tend to look at the functionality of people, more at whether they are in pain or not. And in healthcare, there's a tendency to focus on the outcomes in terms of the health status rather than the pain. So it would allow for more basically more precision when discussing what are the outcomes of care. And because we're interested in efficiency, that's very important, because we need to look at the outcomes, we need to look at the inputs, the expenditure, and we need to compare the two. So if we can understand quality better, that is incredibly useful for us. Then it allows us to assess the burden of chronic diseases more accurately, which is, of course, very, very important when pain can be a big part of that. And to some extent, we can also use that to measure the degree of integration across healthcare and long-term care, and also within healthcare. A lot of the management of pain sometimes can get a little bit lost, after a discharge from hospital, between acute and primary care, can get a little bit lost between the long-term care and healthcare providers. So if we know that, we have indicators for the level of pain, then actually that can allow us to look at that more carefully. And then it can also allow us for the benchmarking of performance at national and international level. This is very important because it's very difficult to know whether the outcomes that you get for specific patients, for specific interventions are normal, or whether they could be made better. And so having been able to compare these outcomes at national and international level is extremely helpful if you're trying to improve the effectiveness, but also the cost effectiveness of health systems and long-term care systems. And so I see all of this as part of improving the basis on which we can try to make systems more cost-effective in the long run. And so that's why I think it's relevant to the work that we have done on this in the European Commission. Our joint report itself doesn't touch on pain that much because it's more at system level than at condition or even outcomes level. But this is a bit the framework of how we think about these things and how I think that these indicators on pain could really help. And that's pretty much it. That's a link to our joint report, which is available for free online. Thank you very much.
For these insights, thank you very much. He is Professor of Neurophysiology and Managing Director of the Biomedicine and Medical Technology of the University Heidelberg, based in Mannheim, I learned. And he is past president of the IASP, and he says, the introduction of ICD-11 is expected to improve pain management. Would you please welcome Rolf Detlef Trede.
Thank you very much for the warm welcome. I think I owe you an explanation why I arrived late. ICD, the foundation of it, is a living document, and there's a medical scientific advisory committee that has a teleconference every month, of which I'm a member. So we just had a vote on, we made 17 decisions just a minute ago about terminologies in the foundation. And it's highly relevant what you heard from Ulrich Vogel, that words mean a lot. And even in the English language version, there are some imprecisions in there. So one of the things we had to discuss was gender incongruence. And one note was, how do you translate the difference between sex and gender into all the languages in the world? So the consequence for you, if you work on your language translation and find something funny, reflect it back to the WHO, because right now it's a little bit stuck in the English language, but the concept should be relevant to all the languages that we all speak. So, yeah. That was not the aim of my presentation here. The aim was to introduce you to a document that we hope to be able to hand over to the health attaché of the German representation here in Brussels in preparation for actually a set of 3 presidencies, Germany being the first, followed by Portugal and Slovenia. And it's going to be about addressing pain as a health indicator by implementing ICD-11 and ICF. Now, to see where the presentation is with respect to where I am. Okay, so I was still on this slide. The second slide includes my conflicts of interest, but also the topics that we discussed at a workshop yesterday, which was about health data standardization. And you may wonder what all these things have to do with ZIP. So the explanation is in these 3 bullet points. So ICD-11, as you probably appreciate by now, is totally different from anything that we had before. It's electronic, it's a database, which means it offers many opportunities and chances in the future that we did not have before. Of course, WHO is interested that people use it. You heard from Ulrich Vogel that it's not so easy to persuade people who like what they have to install any changes. And therefore, if the pain field expects progress from the introduction of ICD-11 and ICF, we could actually help WHO in their quest to implement this. The other thing that you've heard many times here is that digital health really is high on the agenda for the European Union. So if this process that we want also involves digital health and digital instruments, then we also can help the EU to reach its aims in helping member states with the healthcare system. And with this synergy, we can hope that WHO and EU help us to improve pain management. So that's the idea behind it. So there's a background here. So the background sounds like it's a historical report. All of this happened this year, actually in the past 6 months. So it's a really very new type of background. So May 25 this year, the World Health Assembly adopted the ICD-11 classification that had been worked on many, many years, had been expected to appear much, much earlier. The important thing you already heard in Ulrich Vogel's presentation, the vote was basically on mortality reports, whereas the implications where currently ICD-9 or 10 are hidden throughout the entire healthcare system. So many, many implications. And of course, in our case, we're also interested in the morbidity parts. So the challenge is to bring this to real life, and it means there needs to be some policy rollouts across the member states, and some of them are in Europe. So the societal impact of pain industry plans to support this. So there are these policy recommendations that you see at the bottom. So how do I point here? I think I point there, yeah. So this is a document that was worked on yesterday, so you cannot have it in your materials yet. There have been several drafts of it. But what you have are these two infographics that had been prepared earlier and had been available at the time of the EFI conference in Valencia. So these infographics still stay the same, and if we have new ideas, they get into the next document. So you have these two infographics. They have been developed by experts, and now a group of experts has worked on these draft policy recommendations. The workshop was yesterday, and we actually tried to include many comments of what people discussed yesterday into the document that is going to be handed over to the preparation of the German presidency. And this is the real task of my presentation, which is to show you this slide, which is already my last slide. So these are the top-level recommendations that we make, and you see we make a link between chronic pain, the WHO classifications, and digital health. So the first calls for using the WHO classifications in making chronic pain management a European priority. So one of the reasons it can be done is it's for the first time chronic pain classifications are included in any ICD. So therefore, that's novel and can be used. And ICF has certain parameters of functioning in daily life at the workplace and at home that also are novel and will help achieve these aims that we have. The second bullet point here refers to the digital health interface that ICD-11 provides. So the WHO already provides an electronic interface. It also has a human-readable interface where you can look at a browser, you can try out a coding tool and everything. But software apps can do the same thing. So from the WHO side, the interface exists and it's constantly being improved. But it only comes to patients and other people who are stakeholders in this if really the digitally usability is implemented in some software tools. Now, number 3 is an important aspect where ICF could deserve a little bit more attention than before. So since people with chronic pain have a long-term condition, it's really about social inclusion. That's the ultimate point. So the diseases will not go away. Management should improve the situation, and social inclusion is an important part. And we are proposing certain steps to actually improve the social inclusion by using these tools. Now, the last one is a trivial one, or not so trivial, depends on your position, that all relevant stakeholders need to be included. If you look at the list of stakeholders there, IT specialists are added to the list of the usual suspects that we have, from patients to healthcare providers and policymakers. So it's part of recommendations for a digital agenda. We just heard that also the expectation at the EU level, at DG Santé, is that the German presidency is likely to have a special interest in that. And the idea is that we can leverage all this to actually achieve the goal of improving pain management throughout Europe. And hopefully you can witness the handing over of this document if Ortwin Schulte arrives in time before you all leave. This has not been fully confirmed, but hopefully it will happen today. Thank you very much.
Sorry, just got one question. Thank you very much, Detlef, for it's a lot of work to do, I guess, in the future. Do you have any questions concerning ICD 11? There's one question over there. Please, for the sake of time, a short question and a short answer.
My question is addressed to Mr. Ramos. You mentioned that after you assess the quality indicators provided by the national member states, you established the quality, no, after you assess the outputs provided by the member states, you establish the quality indicators. What happens? Do you take a step further? Are you trying to address those indicators considering that there will be a variation, or they become subject of some statistics? Thank you.
You can take this microphone, please.
Yes, thank you. Yeah, basically we have what we call our horizontal assessment framework, where we take data mostly from, as published by Eurostat, published by OECD, etc., as well as some of the data that is given to us for producing the agent report and the data that we got from the. And we basically use that to screen member states and to see which member states have particular problems with the efficiency of the healthcare or long-term care systems, much as DG Santé does, for example, for the accessibility of care or need for investment, etc., etc. And then we take that and we use that in what we call the European semester, which is basically an annual cycle where the European Commission publishes country reports that describes the issues that are going on in member states, and then country-specific recommendations that recommend action in specific areas. And so basically all of this analysis that we do of statistics, etc., in the end ends up there with these country reports that analyze the problems, and then these country-specific recommendations that make a general recommendation in a certain direction.
Okay, thank you very much. I have one question from the Swarmworks technology. If you may display the first question here. It says, will it be possible to standardize the assessment of pain in order for it to be fairly used as a quality indicator? I don't know who can give a short answer about this, and then we turn to the second question. Someone, will it be possible to standardize the assessment? You want to say something?
Well,
or you said, what?
The problem is not the word assessment, but the word standardized.
Yeah.
So this is, of course, there are many tools for assessing pain. I think one thing that we should mention at this stage is that the ICD-11 concept has severity of pain, which is not intensity. Intensity is one aspect, functioning daily life is another aspect, and suffering is a third aspect, distress. So that's one thing that is promoted, but of course WHO does not provide the measurement tools. So I think that the task, the challenge will be how we can adopt existing tools into providing these parameters.
Thank you very much. The next question is, what can member states do to ensure implementation of ICD-11 by 2022? That was a non-verbal answer. What can they do? Maybe you try, surely.
Yeah, thank you very much. Yeah, that is, of course, a very tricky question because it very much depends on the country you are in. So I think it was yesterday the saying that we have the situation of an information paradox. In countries, particularly low resource setting countries and developing countries where we do not have much data today, though there is a huge burden of diseases and we cannot identify it. Maybe for the next years, I foresee some kind of implementation paradox just the other way. So seeing first implementations of ICD-11 actually running in Uganda and Rwanda with electronic patient systems nationwide, countrywide, setting up in an extremely short period of time. So that says something about what's about the implementation to say. So if there is not much that you can struggle around. And I mean, we are talking about huge budgets in the European countries for healthcare. In Germany, it's about a total budget of some 200 billion euros, which are directly or indirectly driven by ICD. 80 billion euros only in healthcare reimbursement in hospitals. If you do not have that implication in your system where the ICD is actually in, then it's going to be much easier to transit to something which actually is not there from something which is, of course, a huge step maybe for us, but a smaller step for those countries.
You say it's much easier if it's a greenfield approach, more or less,
Exactly.
rather than to have
that is,
a big system which you have to change.
So be careful with the meaning also of implementation. The resolution says not implementation, but becoming into effect.
Yeah.
And the meaning of the resolution, that is about delivering health statistics and data for World Health Assembly. So,
With respect to the time, a short answer here and then a short answer from your side.
So I think a SWOT analysis, like the one that Ulrich Vogel mentioned for Germany, will be useful. So what are the current weaknesses? Are there any that you want to take care of? And also, are there any opportunities that can fill these? The interesting thing is that DG Santé and DG ECFIN both mentioned quality of health data. So even if the existing system performs quite nicely for the needs of healthcare providers and so on, maybe to improve the system, you don't know where to go unless you have better data. So there is a chance that even countries with good systems may want to change because they get better data only through this way.
Yeah, thank you. And a short answer from your side, a comment.
So from our perspective, I cannot underline enough the importance of the quality of data. Now, when it comes to the funding, I would like to remind basically that we are in the full swing of negotiations of the next MFF, multi-annual financial framework, and especially of the shared management funds, especially European Regional Development Fund, where the member states now, they are putting forward their needs for the operational programs. What do they need to finance? And equipment, infrastructure, including in the health sector, they can be financed. So now it's up to the member states also to put them on the agenda and to put them in the operational programs should they want to finance this kind of either setting up of the system of transition from ICD-10 to ICD-11. But of course it's a work from the member state side, and then it's on the level of the negotiation with the Commission. From our side, we are supporting this. We are supporting the interoperability. The e-health network has passed the so-called investment guidelines, whereby it recommends the procurers in member states and the EU level to use the standards and specifications from the electronic health record exchange format recommendation in order to ensure an interoperable infrastructure. So the political prerequisites are there, the funding is there, now it has to be also used wisely.
Thank you very much. And ladies and gentlemen, thank you for taking the time and with your brand new information, the latest information, hot news you are working on. And a big applause for this panel. Thank you very much.